Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And today we're going to talk about one of the issues that comes up through your messages to us, your questions to us all the time. And it revolves around that dreaded disease, cancer. So we have two very interesting individuals here today to talk about surgical techniques, how to get involved in advocacy, how to know where and when to have yourself screened. So we're going to start off with Dr. Omar Rashid, who is a physician, a very highly recognized physician, and he's a complex surgical oncologist. Welcome, Doctor.
Thank you.
And he was born here in Broward County, which is very interesting. Love to have our own people back here. And we have a oncology social worker who is Christina Austin Valer. And welcome, Christina. May I call you Christina?
You may.
Okay, I'm going to. Well, welcome. Good to have you here.
Thank you for having me, sir.
Right. Let's start with you.
Okay.
What is prehabilitation? And I know you're involved with a RAS and aftercare, things of that nature. Just tell us, what do you do as an oncology social worker?
So as an oncology social worker, we work with patients who are diagnosed and living with cancer and, of course, their families. Our main thrust in meeting with these patients is in assessing their situation from a psychosocial standpoint. We provide the counseling. We assist them with developing proper coping skills and also in navigating the system in terms of their care from beginning until they reach the end of their care and transition into survivorship.
You know, I apologize, but I didn't recognize you correctly because you are a PhD doctor, and there's nothing more important in the certification of your area than having that PhD and having the license. I apologize to our audience that I didn't recognize your PhD, but I recognize your intellect, so I know that you're
Thank
there.
you.
Thank you for being here. Let me get to Dr. Rashid. Dr. Rashid, welcome back to Broward County.
Thank you.
I know that you've been amongst the world. I know you graduated from University of Virginia, correct?
No, I went to Dartmouth College.
Dartmouth, I
for
apologize.
undergrad. Then I was at Duke University for medical school and law school, and I was at Virginia Commonwealth in Richmond, Virginia for my residency.
Oh.
And then at Moffitt for my fellowship in complex general surgical
Okay,
oncology.
I apologize. Again, that's two apologies in the first 5 minutes,
That's okay.
which is a record around here. But the reason we were talking about Virginia, that's what it was, because I know you were a legislative fellow, right?
Correct, yes, in the General Assembly. I also
Right.
worked for Governor Kane and Governor McDonald as
Right.
well.
But now you're at Holy Cross.
Yes, sir.
And tell us what a complex surgical oncologist is.
Well, it's so as part of my training, I got trained in general surgery, so that included cancer surgery, but also trauma, pediatric surgery, etc. And then I focused on cancer, so I spent a couple more years at the Moffitt Cancer Center. And complex general surgical oncology is a new board certification. I'm the second class that's eligible to take the boards. And essentially, historically, cancer surgery has been done by general surgeons and not by folks who've done extra specialized training in cancer. So my clinical focus is on melanoma, other skin cancers, but also esophageal, stomach, pancreas, liver, minimally invasive, and robotic surgery. And the key thing is when it comes to improving outcomes in cancer, it's not just about doing the surgery, it's about looking at the whole patient, working on a multidisciplinary team with a medical oncologist, a radiologist, radiation oncologists, social workers as well, to really shift our system away from just prolonging life, but actually improving that quality of life. And that's where we do things like prehabilitation, where the minute we meet the patient, we work on their nutrition, their physical therapy to improve outcomes, hopefully turn them into a better candidate for treatment, get social work involved from the very beginning to help them cope with what's going on, get palliative care involved to improve their symptoms even before we start treating them. And then we're showing that when you do that, patients actually have a better experience, they improve their care, they get out of the hospital faster, and hopefully that means longer survival, but more importantly that they have better quality of life, they maintain their dignity, And that's the exciting thing that's going on in cancer. It's scary when you hear the big C, but there's a lot of hope now, a lot of new technology. But you don't want to just start doing things because you can. It's about how do you have it focused and tied to research so we can hopefully improve outcomes here locally in South Florida, so people wouldn't have to travel long distances to get world-class care.
I think people don't understand the issue of cancer.
Right.
It's so dreaded. It's so horrific to them. In fact, I often mention through the viewers' comments to us that the area which they talk about the most, they talk to us about many different things, but the top two issues are cardiac issues and cancer issues.
Right.
Not that there aren't others, but there are many, many things. And when we talk about both of those, they want to know about minimally invasive surgical techniques. Why? Because there's constant thought about pain,
Right.
blood,
Right.
and cutting.
Right.
Yes,
Right?
Right.
yes.
Now, that's oversimplistic terms, but the viewers communicate with us often about that. You, as a new, highly skilled, trained, complex surgical oncologist, talk to us a bit about what you've seen during your education process and some of the changes in the surgical techniques.
Sure. No, those are all very, very important issues. So there's been a big shift in my field towards operating minimally invasive technology that we've done in general surgery to cancer patients. I've done a lot of research on this and published on it as well, where we've shown that in the correct patients that are selected appropriately, minimally invasive surgery is just as safe, accomplishes the same oncologic goals as a traditional open operation. So what we do is, as a part of our early recovery after anesthesia and surgery protocol, the ERAS, it's not just nutrition and physical therapy. We also do nerve blocks and different types of pain management strategies so that patients hopefully will barely need any narcotics at all. They'll have less pain. That way they can, we do big, even our open operations, where we have to take out the part of the pancreas, the stomach, the small intestine, the gallbladder, one of the biggest surgeries, a Whipple procedure. We get patients out of bed the same day of the operation because we had these pain management techniques. Now with the laparoscopic technologies, the laparoscopic staplers, and also the robotic surgery and intraoperative ultrasound, we can do a lot of complex surgery through smaller incisions, which will lead to earlier recovery. But at the very beginning, you have to have a team, in my opinion. It's not just, surgery is just a tool. The operation hasn't really changed much in the last 50 years, if you think about it, technically. What has changed is our collaboration between the surgeon, the medical oncologist, social work, etc., so the patients are getting the right treatment at the right time. I break down 6 steps in terms of beating pancreatic cancer, for example. First, establish the diagnosis histologically. Historically, if you saw something in the pancreas, people would go to surgery first and then figure out what it was afterwards. That's not good enough anymore. Step 2, stage the patient. How advanced is this disease? We have a lot of advanced endoscopists, for example, who can help us figure out how involved this tumor is. And then guess what that does? It makes sure that does the patient need chemo first? Do they need radiation first? Do they need surgery first? The third step is preparing the patient for their treatment. So their nutritional status, checking their heart and lungs, all the steps needed. And then, okay, if they're not good enough if their lungs are weak or whatever, get them on a protocol to improve their function so they can get the treatment. The third step is treating them. Is it surgery? Is it chemo? And then the fourth step is assessing that treatment. So if we do surgery, looking at the pathology, and then determine do they need any other treatment. So you give that adjuvant treatment, and the last step is survivorship. But the whole time the continuum is improving quality of care every single step of the way. I don't want to. All my mentors would be very upset if I were to say, "Oh, the robot's the answer." The robot is not the answer in itself. It's this whole teamwork approach where the patient is at the center. They're showing us what the goals are of treatment. We have these great international guidelines, but it's not a cookbook that says patient has this, therefore do that. You have to personalize it. And hopefully, as we do more research, including looking at genomics of tumors, we can then even personalize that next level, where now we're learning, for example, melanoma, the drugs that are working there, where we use the patient's immune system essentially to fight the cancer, is working in other cancers that are non-melanoma based on genetic testing of those tumor types. So it's a lot of excitement, but I tell you, from my perspective, I'm a surgeon, but I'm a cancer surgeon first and foremost, and what guides me is the biology of the tumor. And our job as physicians and in cancer centers is to help the patients understand those issues and educate them so they can make the right decisions to maintain their dignity and their quality of life.
Dr. Christina,
Yes, sir.
so now we have, you no longer handed as years ago you were handed the patient after the work.
Right.
Now you're right in there at the beginning.
Correct.
So talk to us about it.
So I think that's really important. As social workers, we've always had this view of patients being in the center of everything and really concentrating on all the different pieces. So for us, it's not a new concept to be patient-centered in our approach as we are today. You just heard Dr. Rishi talk about, the patient-centered approach. So that's something we focus on, and I think for us, we always try to go in the very beginning if we can. Now it's a must because our patients need much more. Available resources are shrinking, and we've got to be able to help these patients to navigate that system, starting with the way they cope with stuff, and then to include the educational piece that they need, the encouragement and the advocacy with their team. At Holy Cross, we use this multidisciplinary team approach, which, as Dr. Rashid said, involves all of the different disciplines, whether the doctors, the nurses, social workers, the dietitian, the rehab folks, integrative medicines, and of course, the chaplains, the spiritual component of care. So for us, going in at the very beginning is critical, and then maintaining that relationship with the patients throughout the care until they reach the end of their treatment and transition into the survivorship care.
It's always been part of the, in quotes, social welfare, social workers world, has been the psychosocial issues.
Correct.
And now you've added onto it the multiple issues that the surgical team is asking you to be involved with. So how do you involve nutrition and the issues of family, I should say, psychological compensation, in essence? How do you get them involved?
Right. So it's not so much that we've added on the multidisciplinary team. That is the approach that's used in the hospital, and we are part of that. We're incorporated into that. We network with everyone on the team. I mean, we provide education not just to patients and their families, but also to the different team members about different things that are happening with patients. It's important, for example, if the doctor is going to be performing the procedure, that he knows something that's critical to how the patient is coping, or some deficit that the patient might have that we've uncovered in doing that initial psychosocial assessment. And it can range anywhere from having, of course, some mental health issues to, of course, being on the verge of being thrown out of their home. And so patients don't necessarily tell everything when they come in because they want to get treated. I mean, cancer is the number 2 behind cardiac. And so when you mentioned that those were the 2 things that people sort of talk about the most, it's because they're the 1 and 2 issues in terms of health. And so they may not say that they're on the verge of being thrown out. It's a big issue, but the bigger issue that they're faced with at the moment sometimes is, of course, having cancer. And so we have to help them to navigate that piece. We've got to be talking back and forth throughout the team, connecting all the pieces so they know, okay, so we're going to do surgery on this patient, but this patient is about to be thrown out of their home. So what do we need to do to make sure that once we do this wonderful procedure and we've arrested or removed this disease part of the patient's situation, the body, that then the rest of the care can go smoothly, that there is a place that the patient is going to go beyond the hospital setting once they've gotten to the place where they're safe enough to be discharged. So we do have to keep up with all of those pieces in addition to making sure, of course, that the patient is coping well and connecting the family. Sometimes there are family dynamics that become a barrier to them getting their care. Sometimes it's transportation. What if the patient can't get to the hospital and do even the workup, let alone the surgery? So there are many pieces that we look at.
It seemed to me that one of the biggest problems that faces the team is the belief that when someone has cancer, they say, am I going to die?
Right.
There's a big stigma in our culture, meaning mental health obviously too, but cancer, everyone's afraid of it. But look at what's going on. Look at Jimmy Carter with
Yeah.
melanoma. That with these treatments, I mean, when I was going through training, melanoma was considered a death sentence. In the
Yeah.
last 5 years, huge changes.
Very huge.
Other disease, hepatitis C, we have a cure for it essentially. There's a lot of excitement, a lot of change now where patients have options. Part of our duty as physicians who focus on cancer is staying up to date, being involved in research, offering these trials to patients, and then going out in the community. I've been involved in
educating.
sessions where I've gone out to do just regular educational seminars to local folks about, look, this is how you screen for skin cancer, for example.
Right.
These are the things to look for. These are the treatments available. The goal is hopefully we catch it early so you don't need these advanced treatments.
That's the key.
But year after year over the last 20 years, cancer survivorship has improved. Breast cancer is not a death sentence anymore. There are bad cases, but there's a lot of hope. It's funny, when someone has a heart attack or a stroke, it's not considered to be in most people, right? I mean, you have the same experience in social work, where when someone has cancer, they freak out and they think it's over, and
Yeah.
it's not. There are a lot of options. There are a lot of resources in your own community, and part of our job is to get out of our cancer centers, to go out and say, look,
Educate the
guys,
community.
there's a lot of hope out there. There are resources available.
Well, I think, again, a lot of that relates to the fact that there are, not only in the state of Florida, but in the United States, there are limited areas. People know of the big names. I'm not going to name the names. The
Sure.
big names where people go to, to go to Texas or go here, go
Right.
there for their cancer treatment. But now with the diaspora of physicians who are trained and other members of the team, everybody from the social workers to the nutritionists to the oncologists to the infectious
Physical
disease
therapy.
folks,
Right.
the pain management people.
Right.
Now all of a sudden everybody recognizes, hey, we can get a heck of a lot better result. I'm making it oversimplistic from this patient. We can give them a quality of life.
Right.
We can not only succeed in enabling them to live because they're not going to die,
Right.
Right.
but we're going to give them a quality of life that maybe was even
Better
than
before.
what they came to us with.
Right.
True.
Correct.
Is that too?
Yeah.
is that-
No,
No,
you're right.
it happens.
And the other thing is, so at Holy Cross, because our cardiac and our orthopedic surgery is so good, we in cancer have taken advantage of that. Our intensivists are incredible. So we have strong pulmonology, strong cardiology. So a lot of patients need this prehabilitation or rehabilitation. We have incredible physical therapists because they're taking care of people having joint replacements, having open heart surgery. And they push the technology. So we have interventional radiologists doing amazing things. And it's like, let's bring that to cancer. And there's some things that can be done at hospitals where you're doing advanced big cases
Absolutely.
that other places, other cancer centers aren't necessarily doing. So really, and for someone like me being committed to the area, being from here, my parents are still in the
Right.
community. My grandfather, he himself is a cancer survivor. It's one of those things where we can do better. And actually, our institution has been partnered with other places up north where we can offer clinical trials to patients if they meet them. And I'll tell you, having been at these other places, everyone knows in the cancer field too, we'll give an opinion, but it's better for the patient to get their treatment locally, close to their families.
Absolutely.
And these drugs are available all over the planet now, and these trials in many cases as well. So if you can do it, the patient should know what all their options are.
You mentioned genomics, all right, before, and a lot of people are starting to see the word, or they're hearing it, but they really don't know what it really relates to. In an oversimplistic term,
Sure.
tell us what's going on.
So basically, every tumor is different and every patient is different. And so what we're finding out more and more is that if you look at the gene signature, kind of what genes are overexpressed or underexpressed in the tumor, they become targets for therapy. And that's been happening in breast for a long time, where a woman will have breast cancer, they'll do a lumpectomy, they'll do a special genetic test on it, and it gives what's the risk of it coming back, and therefore they can have an intelligent conversation, personalized conversation with the patient, but what are the potential benefits and risks of chemotherapy? And based on that, they guide their treatment. Similar things have been going on in colon cancer, and as well now in melanoma. But more and more, the thing is, there's so many genes out there in the tumors. We're realizing more and more that precision-based medicine, the federal government's pushing it as well, but all the cancer societies as well. The goal is, ideally, one day in the future, it's not going to be pancreatic cancer or breast cancer. It's going to be look at the patient's genetic profile, look at their tumor genetic profile, and then tailor the treatment based on that. And ideally, do it before you start any other treatment.
Right.
And just like I said about those 6 steps, starting with confirming, getting all the information before you start treatment, knowing your enemies, so to speak, and having a targeted strategy towards them, it's the same thing. That's the exciting thing in cancer. So in my view, and granted I'm biased because I've done a lot of research, and I really believe in this in the future, I think patients should have, they should have the opportunity to look into research and say, okay, how can, and research that'll benefit that patient.
Right.
Ideally, to have that tumor gene sequenced, and then their information get put in a database so that the minute a new trial opens up that they might benefit from, they're alerted automatically.
Right.
Not just some downstream benefit to cancer patients in general. And I think it's already happening. We're working on doing that now. But I'm hoping in the next 10 years we can get some more fruit sort of born from that tree and all other cancers. And, and it's exciting. I mean, that's the exciting thing about cancer. And the challenge for us, I think, and my profession hasn't done a good enough job, to spread the word out so people aren't as afraid. They're afraid enough to do screening, to live a healthy lifestyle, to come see the doctor, so they know it's important, but they shouldn't be paralyzed by it. And that's where I'll tell you, working with the social work team has been great because they're phenomenal in terms of going in there with the patient, following up, to educate them and to empower them. That should be our message. If anything, yeah, there are a lot of technologies, but our goal is to help them work through it in a way that's right for them. And the spiritual component too is an important part of that, because people have to have a sense of meaning in what they're going through.
Higher power.
Well, you know, in talking to a classmate colleague of mine who is now emeritus at the Columbia Presbyterian Hospital, and he was talking about the amazing results. They just did some publications on the issue of meditation and integrative medicine.
Yes.
And I'm not going to talk to you about integrative medicine, but spirituality is certainly, and again, it depends upon the situation. I mean, but meditation in essence is a form of spirituality.
It is.
You find that to be?
It is, and we do offer integrative medicines to our patients. I, for one, do offer visualization, meditation. We have massage therapy, we have hypnotherapy, we have acupuncture, qigong. There's a whole host of different programs that are provided to our patients. Any patient that is treated in our cancer center has access to that. In fact, a couple of days a week, we have some of the integrative folks come over and do their treatments with the patients while they're getting their chemo treatments in the infusion department. We've got chairside massage going on. We have healing touch going on, so that the patients get introduced to this. This way it encourages them and it engages them in a way that they know that this is part and parcel of therapy as well. So it's not just the surgery, it's not just medication, but also to be able to incorporate the Eastern type, integrative type medicines that will help them. And it's been beneficial.
Well, again, in observing this and talking to my colleague, he said it's amazing how we brought the human spirit back into medicine.
Yeah,
that's what he said to me.
Absolutely.
Yeah.
And I not that it hasn't been there, because like I said, I don't want to demean or denigrate any of the wonderful professionals that have been providing care for so many years and helping so many people. But it's interesting to hear that coming from one of the major, I guess you could say, cornerstones of healthcare in the United States. And he said to me that it's really a wonderful feeling to know that we've been able to incorporate some of these things and make it so much better for the patient. He says not better relative to the procedure, but better to the outcomes.
Right.
Yeah, and it feels, I'll tell you, as a physician, that's the fun part of the job, to be honest. Every patient is different.
Right.
Every cancer is different, and really trying to make them feel better even before you touch them, and watching them make that progress.
Yeah.
We have these scales these frailty scales and other performance status scales, so we can quantifiably see how is the patient moving forward. I do the same thing with distress, obviously, in social work too, but so we can see what's their starting point. We measure someone's weight and their temperature, but how do we look at their whole person so we can quantifiably see improvement? But that's the best part of, I think of in Patch Adams, where they say you can't cure everybody, but you can heal them. The same idea. And then to come back to my own community and improve that level of care, and then engage also young people to be involved in research and spreading the word. To say, look, all of us have to join this fight together. That's how you improve the outcomes.
Well, we're down to the last 1.5 minutes of this show, but I want to ask you a question, and that is, how do we, I would assume that in your area or your department or your compendium of individuals, that you also provide opportunities for people to hear you, make presentations or things of that nature. How can they reach you?
They can reach me at, do you want my phone number as well?
Whatever you want.
So they can reach me by calling my direct line, which is 954-267-7700, or they may email me at chris.austin-valer at holy-cross.com. Or, of course, they can always call our Community Relations Department at Holy Cross Hospital. And the main number, of course, is 954-771-8000. And just ask for
Do you have
community
outreach
relations.
community programs and things of that
We
nature?
do.
Okay.
We have lots of, we do support groups, which is open to the community. We run a program twice a year in the spring and in the fall. It's called I Can Cope. It's an American Cancer Society signature program. It's an all-day educational program. It's open not only to our patients, to the entire community. In fact, all our support groups are. And we've got several of those as well.
Good, I'm glad. Now I'll report to Barbara Effman that you're doing a good job.
Oh, you know her.
Okay, now Dr. Rashid, we thank you very much for being here. Welcome. Like I said, it's so wonderful to have one of our homegrown experts in the field come back and provide the care. It must be exciting for you. I'm very pleased that you're here. All we care about is that they have a better life opportunity, and not only that, but they have a quality of life which is better. So I want to thank you very much. Dr. Austin Valer, thank you very, very much for being here and for your advocacy. And Dr. Omar Rashid, welcome home.
Thank you.
I'll wave to your
back.
parents.
They're very happy.
I just found out his parents live in, or I live in their neighborhood. How about that? Whatever. But whatever it is, we thank you very much. I hope you come back. And good luck on your magnificent career to be.
Thank you.
Thank you. Folks, I hope we provided some interesting information to you. If you have any questions or comments, this is a telephone number and an email address which you can contact. Feel free to do that. And remember, as I always tell you, you got to take good care of yourself. That means, and we never got into this, that you got to see your physicians, your primary care physicians, your OBGYNs, your internists, your family doctors, etc. You got to see them, and you got to take care of yourself, because the quickest way for these wonderful people to work is if you give them your problems early on. That's the best way. So thank you once again for showing up, allowing us into your homes. Remember, this program is called Dateline Health. We come to you from Nova Southeastern University. And until next time, see you.